Okay then, here we are at the last session of the day. Can't have a conference without a question time, I think, and an open forum, and that's exactly what we're going to have now. So I'd like to start by introducing the panel, and a very illustrious, distinguished group of panel members we have too. So let's do a few introductions. On my near right, Ash Soni. Now Ash probably has one of the longest CVs in pharmacy, but I'll give you the short version. Ash is a pharmacist and a pharmacy owner in Lambeth for the last 26 years. He's been a member of the NPA, PSNC, a supplementary and independent prescriber, and a member of the NHS Future Forum. He's currently the clinical network lead at NHS Lambeth, and last but not least, was awarded the OBE for services to pharmacy in January. So welcome, Ash. Next, Ash, is Katy Parsons. I'm delighted to have Katy on the panel. Katy studied pharmacy at the University of Huddersfield, graduating in 2012. She completed her pre-registration year in community pharmacy. Is it Tadcaster?
Pickering. You don't know where that one is?
No, I don't. And she's currently the rotational pharmacist at Hull and East Yorkshire Hospitals NHS Trust. Katy was the Royal Pharmaceutical Society Student of the Year in 2011 and has enjoyed a long association with the British Pharmaceutical Students Association. In fact, she's currently the BPSA President. And Katy and her peers represent the bright, progressive future of the profession, and we're really delighted that she can join us on the panel. So, Katy.
Thank you.
Next to Katy is Peter Dawson. Now, Peter may be unfamiliar to some of you, but his writing won't be, especially if you're a Guardian reader, where Peter writes very perceptively and forcefully on pharmacy and NHS issues in general. And for those who say pharmacy and pharmacists have had too low a profile in the media, that's until Rob was telling us about his stuff just now, but they clearly haven't been reading Peter's stuff, because it's very thought-provoking. Now, Peter works as a locum pharmacist in West Yorkshire, is a keen exponent of evidence-based practice, and has strong views on, amongst other things, the role of the pharmaceutical industry. And he's also an enthusiastic blogger for some obscure pharmacy trade title whose name escapes me for the moment. Begins with C, I think. And next to Peter, we have Sheila. Well, what more can I tell you about Sheila? Now retired from the PAGB after 29 years. And I'll come back to Sheila a little later on, actually. But what I will say, I think it's very interesting now to hear Sheila's views and perspective on an industry she knows so well before she heads off to do some different things in life. So please welcome all our panellists. Okay, format of the session, just like question time on the telly. You ask the questions, we'll have a roving mic that will pick you out, and the panel will do their best to answer them. Don't be spectators or walking dead, to borrow Andrew's phrase. Being a cynic is fine, but this really is your opportunity to ask anything you like, actually, about pharmacy, about self-care, about what you've heard today. So please make the most of it. But to get the ball rolling, I'd like to exercise Chairman's prerogative, and I'd like to ask the first question, which is this. And this actually reflects a lot of Twitter activity that's been going on while we've been having the conference. The Twitterati has been going bonkers out there. Now, conference has heard a lot about improving customer experience, what constitutes high-quality customer service in pharmacy, and how pharmacy should put consumers, customers, right at the centre of their self-care offer. But let's consider the example of electronic cigarettes, and this all stemmed from Martin's excellent presentation, which kicked us off this morning. Because here it could be argued that, driven by clearly enormous demand for these products, pharmacies who were stocking e-cigarettes And devices which are, after all, safer than smoking, and it's nice that says that, they are indeed putting customers at the centre of their offer. But these are unlicensed products. There are no guarantees about their efficacy, quality, or even safety. So the questions that were coming in from Twitter, a lot of them were, should pharmacists be stocking them at all? And I think I'll put that to Ash first, and we go across.
Thank you. Thanks so much. Interesting, because of course the RPS has a position which is that it's unethical currently to stock. And it is because of the variability in the products and the lack of consistency or assurance that actually what you're able to supply is of a standard which is suitable for medicinal use effectively. Because in a way, whatever you say, what we're trying to do is replace, for those people that are using cigarettes, nicotine, the nicotine from that in another form. So therefore you are using a medicinal replacement. And there is a concern around that. However, I think there are some issues about supplying the product that doesn't stop us being able to support people who may decide to take that route. So I think there is a piece for pharmacy to recognise that people are using e-cigarettes, but to use that as a lever to be able to start to talk to them about the fact they're looking for an alternative. They're looking for something safer. That's why they've done it to start with. And actually seeing that as a stepping stone to the process of giving up. And therefore, I think they can be part of a smoking cessation programme supported by pharmacists, even if they may not be supplying the product.
Okay, so Katy, I mean, you'd agree with Ash, I think. Whilst in a perfect world, maybe we wouldn't have unlicensed products available from pharmacies, but if they are going to be available, like Ash is saying, isn't it not better that they are available from pharmacies rather than somewhere else where they maybe can't provide that level of care and attention from trained healthcare professionals?
I don't want to sit on the fence, but I don't like pharmacists that sit on the fence. But I'm very much of the opinion that if we want patients and the public to be good at self-care, that pharmacists, the medicines experts, and our key role is patient education. So even though, regardless of whether a decision is made, whether it becomes a medical device or not, the e-cigarettes, and whether if pharmacists do stock them, there's an opportunity there, and there is a control there in the pharmacist being there to be able to intervene. Whereas currently, at the moment, they're supplied from salespeople who have had, a couple of hours training, and they're trained to market the product, not to assess whether an individual is suitable. So I'm very much of the opinion that pharmacists should be there to intervene, and should it come a point where they become licensed, then that justifies its position in a pharmacy.
Okay. Peter?
I think I disagree.
Oh, good.
Very respectful. I think it's a really interesting topic, and I think that it crystallises one of the fundamental dilemmas in community pharmacy, namely some may say paradox, others might say the counterpoint between commercialism and professionalism. Community pharmacy has had this Jekyll and Hyde problem for a long time. Every transaction in a pharmacy doesn't have to lead to a sale. We are there, I'm talking about in a public health context. We are there to help people. The really fascinating presentation this morning on it suggested, if the speaker's here, I want to be corrected if I'm wrong, but he seemed to suggest that the e-cigarettes were taking a market share away, if that's the right word, away from the prescribed nicotine replacement products. I think he said 4%. Okay, what does that mean? Well, that means that we had patients who are part of a controlled smoking cessation nicotine replacement program, and they've opted out to take these nicotine vapor products. Well, that's grossly irresponsible. Secondly, in the same way that I believe there is no place for aromatherapy and homeopathy and any other healthcare practice for which there is no sound evidence base, I think it would be grossly unprofessional of pharmacy to start selling a product that isn't even licensed. I mean, you know, and even if it does become licensed, there is no evidence to support it. And the third thing I would say, and now I stray into the world of a little anecdote, I suppose, but my 18-year-old niece tells me that we're dealing with fashion accessories. And I read that BAT are investing a lot of money into these products, and these products, in my opinion, are being used to teach young people how to smoke. It's a reintroduction of the smoking habit. So if we consider ourselves to be worthy members of the public health community, we should not be stocking these on our shelves.
Okay, thanks, Peter. So I think Ash is a yes.
Not stocking,
Not
provide
stocking.
support.
Yeah, not stocking, providing support, so that's kind of 50-50. I think Katy is...
Oof, well, who knows?
Yeah, probably more than not because of the intervention possibilities. Peter, definitely not.
And just so my credibility has some remnants, one of the things you didn't mention in my sort of dark and shady past is that I was in fact a proprietor pharmacist for a number of years. So I'm not talking purely theoretically, you know, I'm talking in a very practical sense.
Thanks for making that point. So, well, Sheila, what do you, from an industry point of view, where do you
I'm
stand?
closer to Peter on this than the rest of the panel. I mean, let's get real. If you look at where e-cigarettes are now, they're largely being used by people who are currently addicted to tobacco products. My sister-in-law's tried to cut down by swapping to those when she can't smoke. She's a 60-day smoker. So the whole discussion at the moment is about those kind of people switching down to nicotine-containing electronic cigarettes has got to be better than having them to continue to smoke. And that's almost a given. No one's really discussed what happens when someone who's never smoked at all before, like me, you know, decide one day I look quite cool with an e-cigarette. So I become addicted to nicotine. So I don't know why pharmacy is even involved in this at the moment. You know, it doesn't seem to me anything approaching a real health issue there. However, fortunately, the MHRA has got a handle on this, and it says they should be licensed. And licenses in the same way that other NRT products are licensed as part of a give up, not just swap from one thing to another. So if they're all licensed, then why shouldn't pharmacists sell it? They sell any other licensed product. And I think there's going to be a lot of encouragement to manufacturers to go that way. And some of them already talking to us at PAGB about that.
Right, well, I'm going to pause. Very good answers, thank you very much. But before we perhaps come back to the panel, if they've got anything they want to add, but now we just open it up to you guys. You can continue this theme if you want. I think it's very interesting. Has anyone got any points they'd like to make about the e-cigarette situation at the moment? If you could stick your hands up. In fact, right down the front, please. Back over to Martin. Thanks, Martin.
Yes, just picking up on Sheila's last point, which, and you were saying, what about people who haven't smoked, who might be tempted to smoke by e-cigarettes? I was reading some research which suggested that that wasn't the case. So if you look at the population of people consuming e-cigarettes, hardly any of them were coming into it not from tobacco. I can't remember the research. David Mitchell sent me the link, so...
I suppose I'm a victim of where I come from. I spend a lot of time, over-the-counter medicines are supposed to be non-addictive. We spend a lot of time, you know, making sure that that's the criteria being applied, and that if they are addictive, they're prescription only. And then we're now talking about something which is addictive, but we think it's okay because it's not as bad as tobacco. I mean, if that's the new criteria, then there's going to be lots of other opportunities for new and more interesting things in pharmacy in future.
Well, I think there's a danger, though, isn't there, that the potential size of this market, the attraction and the profits to be made, and the profits are being made by, you know, unlicensed manufacturers. It all started outside even the mainstream grocery sector in terms of distribution. And there's a degree of advertising which is possible for these products which isn't for tobacco, that could at some point happen. And if the pharmacy world isn't part of that, then it makes it more likely to actually happen. Whereas if pharmacies embrace, and this is only a view from someone who's not, I've got an opinion from what I see, but you know, I probably haven't got a stake in it, if pharmacists are involved in the process of these products helping people to quit, then they'll be associated with that as opposed to some sort of glamorous tobacco replacement.
Okay, yeah, thanks, Martin. I think we'll ask Ash and Peter to come in here. Ash?
Just three things. These products are not currently licensed, but they are going to be. And I assume that once they are, there wouldn't be this position about whether the pharmacy stocks them or not. Actually, we have programs today which are not just about smoking cessation, they're about reducing. They're step-down programs, which are seen as being a part of the program of care that people have. It isn't always now about that quit. Public health, some of the public health messages and some of the products that are available are designed to work in that way. And the third, interesting, I had a conversation with my Director of Public Health last week, and we were talking about people generally. And her comment to me was, what we need to do, she was talking about asthmatics and COPD patients, we need to invent an inhaler which works like an electronic cigarette, because by God, people use it. Well, actually, if I've got a Director of Public Health starting to move into that sort of language, we need to start thinking not necessarily about what the product is, but what it offers and what that gives us that may also be different to where we are today.
So, Peter, does that situation depend, in your mind, on licensing or not? Is the fact that it's unlicensed without those guarantees that I mentioned is giving you your concerns?
Right. Okay. First, let me respond to Ash, if I may. I agree. And I would suggest that is such a very, 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 very small proportion of those patients, those people trying to quit. Licensing. My understanding is that the licensing is all about safety. Well, that's not enough. I mean, I actually don't think that merely selling products that are safe without evidence of their effectiveness, I think that's unprofessional. So there is no evidence, and by definition it will take a long period of time to accumulate the evidence that the vapor cigs can be effective as part of a step-down, etc., program. So I'm saying that, okay, it's licensed. No, we still shouldn't stock it because there's no evidence that it works. And I also feel there is a strong body of opinion that they are designed to encourage young people to develop a smoking habit. I think they're appalling products.
No, that's not sitting on the fence there, Peter. Very good.
But the inhalator...
Katy, I'll come back to you. Katy, you
Sorry, Ash, for cutting you.
No, that's fine.
I was going to say, if pharmacists omit their responsibility in their wider public health role of looking after public health, we're turning our backs on a massive market here and a massive population that need our help. So surely it is better to intervene than it is to ignore. And it's going down the line of counterfeit medicines. If a patient can obtain a medical device, a licensed medical device from a registered pharmacy premises that's been obtained in a safe manner, or they can go on the internet and get a counterfeit, or potentially a counterfeit medicine which is unsafe, then surely pharmacists still have a duty of care to whichever category those patients fall into. We still have to look after them.
Ash, that's persuasive argument.
Absolutely, and there is a whole issue about how we are supporting people in their health. And that's part of what we're trying to do. And actually, the fact is, these products are currently available. They are being used by people. We have to accept that's the case. We don't turn around to people and say, just because you happen to eat lots of cakes and chocolate and everything else, that we're not going to support you for a weight management program, because that would be the same scenario. That seems bizarre for a profession that is supposed to care for people. And the other thing that strikes me is that we do a product which is like an electronic cigarette. It doesn't have the status of it in the terms of that coolness look or whatever else everybody else wants to call it. It's called the inhalator. It is a mechanism which releases nicotine through inhalation into the mouth and therefore provides that nicotine replacement. So we already have a version. We just don't have this version. And the reason we don't have this version is because it isn't licensed. Actually, once that changes, I don't believe that the suppliers of NRT products today would feel that they shouldn't supply it, because actually it would be in their interest to be able to find other ways that help to support people to give up smoking, because that has got to be where we have to get to. I understand the risks that we have around people that may see these as things that they want to see as an opportunity to start, and I do worry about that and the influence of the big tobacco companies and their view. But actually, in a way, maybe if they were licensed and you took some of that away, it would no longer have that status, and actually that would be one of the things that would drive out that market. So in a way, I put the emphasis on the MHRA about how quickly they can get us to a position where we do have fully licensed products.
To Sheila before throwing it open.
This discussion was almost the same one that happened in the European Parliament a few months ago.
Yeah.
And the concern was that the tobacco companies would just go into electronic cigarettes, and this would be the extension of their market. And so what's come out is a whole pile of recommendations for bringing their marketing and advertising under the similar, almost tighter controls than you have for cigarettes, tobacco, and the equivalent of a notification scheme, so that the devices themselves are being better regulated. So those bits of it are being put in place, but it will take a couple of years to do that. And I think that's, if you can't advertise them with a celebrity and a cool ad on TV, then, you know, being able to advertise them as a medicine will start to look like a benefit.
Peter, I will let you come in. I just want to make sure that there's no one out there who wants to raise any questions at this point. We've got a mic down here, coming to you. Yes, sir.
I actually think it raises quite an interesting point on a broader view, if you like, and that is there a dilemma? So that's my question, in terms of the self-perception from the pharmacy industry's perspective, in terms of the fact that we're constrained by an ethical approach to medicine versus the public's potential perception of wanting something slightly different. So they, in this example, using the e-cigarettes as an example, they want access potentially to something that will give them an alternative to the current existing smoking cessation products. Mm-hmm. If we're not a part of that debate, potentially, it creates an issue for us where we don't get access to therefore have a greater impact on their health needs.
Absolutely. Agree.
So my question is, do you feel there's a dilemma there or not?
I think the industry has got a role to play, and actually the industry should be trying to see how they could push this and be able to change some of the behaviours that we got as a consequence of where we are today. And I know there are issues around how the MHRA will and when they are ready to license, but I do believe there is a really key role for the industry in helping to support pharmacy and the public in terms of their health outcomes.
Okay. Peter, I said...
Well, no, I'd agree with that. I mean, that's you know...
Okay. Very good.
Damn, we end up agreeing.
Total agreement, I like it. Okay, any other questions, either about e-cigarettes or not? We'll come over to Nigel at the back now.
Yes. Hello there.
Hello.
I was just picking up on something which Peter said about the competing pressures in the pharmacy of commercial versus professionalism. And as the government is encouraging pharmacists to be more in front of the customer, the advanced services, the enhanced services, as well as delivering effective self-care, so the clinical role of the pharmacist increases. My question is one about perception, and do we consider people who come into the pharmacy to be customers or patients? And it's been interesting today because I've heard them referred to as both, and interestingly enough, if it is about a clinical matter, they suddenly turn into patients, and then they turn back to customers when it's something else. And is that one of the fundamental problems, that we don't know if we're shopkeepers or doctors?
Well, the customer patient that we've often, this is a journalistic nightmare, because I think you'll find that we swap between the two depending as well. So we don't really know what to call them. What would you say to Nigel's question there?
They are customers. Even if they become patients because they're prescribed something, they're given something in a way, they become dependent as part of that. And I think we need to stop referring to people as patients, because actually, if you get to a point where you demedicalise and provide people with the ability to be responsible for themselves, you reduce that dependency. And part of that reduction is about treating them as customers. And if you treat them as customers, they are more likely to share in the decision that you reach, rather than the current position, which is very much patriarchal still, and saying, we will do unto thee, and you will decide, you will accept what we tell you. A bit of the discussion we've just had.
I mean, Katy, you work in hospital. You call patients in hospital. You wouldn't call them customers.
Yeah, it's a debate going on in our hospital. It seems very much that if they're in an outpatient pharmacy and very much in front of you, then they're a customer because they're waiting. But people seem to overlook the fact that we have trolleys and trolleys of medicines and drug cards, but they're not customers because they're patients. And I just think, I can't reel off the definitions of either, dictionary definitions, but they're two words, and to me, whichever one you pick, as long as you have their best interests, then it doesn't really matter.
Very good. Peter, customers or patients?
They're customers. They're customers. And the customers with whom we should be engaging really long-term relationships, as described in the John Lewis presentation. They're customers who should trust us. I believe quite passionately in the public health contribution that we can make to them. And I agree with Ash that there's a real tendency for a degree of paternalism when we're talking about them using such terms. However, that conflict hasn't gone away. You know, the professional commercialism bit. And I've brought a quote with me, and it's from that other rag. And
I close my ears.
And the headline, this was from last year. Headline, pharmacy sales hold as painkiller purchases soar. So, you know, the retailing commercial pharmacist cheers. 2 days later, BBC News headline, in response to some nice guidelines. Overuse of painkillers causes headaches in over 1 million people. And so the professional in the pharmacy sighs. So there are issues that we have to come to terms with. And there are contradictions, which is why I thought the work that Rob Darracot's Pharmacy Voice does is great. I'm a great supporter of it. I'm a great supporter in self-care. But I worry that, for example, the self-care agenda, which should be about returning the healthcare destiny to the individual, it should be about demedicalising, can be, and similarly with the minor ailment schemes that are up and down the country, they can be subverted, and that transaction of which is essentially an information educational transaction can be seized as an opportunity for a sale, perhaps inappropriately.
Well, Sheila, we've discussed many times over the years minor ailment schemes for and against. I mean,
we usually compromise on the customer-patient thing by calling them people. It's a bit neutral. I'm not at all worried about this. You know, somehow it's wrong to be commercial. Everybody's commercial at some point. And the self-care way we describe it is a continuum. So it's everything from lifestyle and keeping healthy through to, you know, in an acute hospital bed being looked after by somebody else. And at that end, you're a patient. You have no choice what happens to you. But ensure that in pharmacy, you're a customer. You have a choice about which pharmacies you use. You have a choice about whether you take the medicines or don't take the medicines. And whether you call them a customer or a patient, whichever you're happier with, it's about doing the best you can for them. And if you also make some money out of it, what's wrong with that? If you're standing in a hospital pharmacy, someone is paying you. You know, if you're making money by selling the medicine, someone's paying you. But hopefully you're not selling the medicines, you know, to the detriment of the person in front of you. I don't think many pharmacists deliberately set out to do that.
No, this is professional commercial schizophrenia. Terry Maguire.
Oh, but I love the doctors go on about it all the time.
do.
Pharmacists are commercial. Have you been to the doctors recently?
Yeah.
They charge for everything these days.
Well, a doctor wouldn't do something without being paid for it. It's a starter point.
Look at what they did with the quaffs.
Yeah.
You know,
Oh, I love a bit of Dr. bashing. Where did that come from?
I got into the doctors. You know, I was a absolute wonderful patient they wanted. I went in and had a bit of high blood pressure. Suddenly, I'm having this battery of tests for diabetes, liver function, blah, blah, blah. And I think, God, there's something seriously wrong with me. And then I found out about quaffs. You know, just me by myself was probably good for another 10 or 15 points, and God knows how much money to help the doctor reach his targets.
Let's not get bogged down with quaffs.
Don't get me started.
There's a question at the back, I think. Hi, Andy.
Hi. I just bring it back to that self-care question. So with 1 billion packs of OTC meds sold every year, is this the ultimate in self-care? It's self-funded and it gives the government back 20% ultimately of the cost price. My question is, does pharmacy value this as a service, or does it only value services paid for by the NHS?
I'll start with Sheila on this, because sometimes you said in the past that pharmacy is so being corralled down the NHS route, and it's forgetting about that really important part of their business which comes in front of shop, and this kind of almost a fixation sometimes on getting within the NHS family, and forgetting the other aspects of the business. So would you like to answer?
If you look at the
there?
balance of the business, if you've gone back about 30 years, there probably about the same number of OTC packs would have been sold. What's happened is that the prescription volume has gone up and up and up over all that time, and pharmacists have to keep meeting that huge extra demand. Last time I worked in pharmacy was a long time ago, and doing 100 items a day you were a bit tired at going home. But now the number of items that they have to churn out day after day is unbelievable. So while I would love them to spend 50% of their time doing OTC things, well, I understand when they say 80-90% of my business is coming from the NHS. I have to focus on that. It's completely understandable. So it needs a different model or different distribution of work between the pharmacist and other members of the team if they're going to be out on the counter. I mean, some of the new products that Martin sold, line extensions, are things, improvements that are about better pharmaceutics, faster actions, different ingredients. You need knowledgeable staff to speak to the customer and say, this is different or it's better than something you've used before. And that's what industry kind of gets frustrated about.
I mean, Peter, the practice model is clearly creaking in pharmacy. There is a capacity issue, and workload is going up and all the time. So how can we begin to rebuild the practice model, perhaps in a way that refocuses attention on the patient rather than just chasing the script volume, because that's where you get paid?
It all comes down to money. It's the remuneration model, isn't it? I mean, at the moment, the remuneration is on quantity of service rather than quality of service. And as a pharmacist, I much preferred being a counter assistant than I did being in the dispensary, which was pretty boring, actually. I'd much rather be out there talking to customers, people. But at the moment, the pharmacist is in a bind, because that's how we get paid. How many health professionals are asked to jeopardize their income in order to optimize patient care? So, for example, we are expected to rationalize prescribing, reduce the number of prescriptions, and slash our own income, our employers' income. I mean, it's insane. It's utterly... It can't happen anywhere else. So, if your question is how do I think that the model is, as you quite rightly say, it's creaking at the seams, and we need to look at alternative remunerations. And I'm sure I was talking to Ash earlier. Can speak more eloquently than I can about getting a remuneration on outcomes. Outcome measurements. That's how we should be paid. Not process.
I'll come to Ash in a sec. Katy, would you like to add anything to that?
Yeah, I just think that, well, it was part of my degree, actually. I remember being asked the question what if you could pick what community pharmacy and hospital pharmacy could look like, what would it look like? And I won't bore you with what I wrote, but it was 10,000 words. It was bigger than my dissertation because I went off on one. But it's part of utilising your pharmacy team. In an ideal world, I'm a strong believer that a pharmacist should be on the counter and should not cower behind a dispensary or hide behind their dispensers, which is what they have been accused of in the past. And contrary to popular belief, yes, I am a hospital pharmacist, but I do have 8 years prior to that doing the rounds in community. I've worked for the 2 of the multiples and did my pre-reg in independent, so I'd like to say that I've got a snapshot of everything, and I've seen good practice and I've seen bad practice. But it's just the point of, again, you need to communicate with patients, regardless of whether you're handing them a medicine that's got a label stuck on it because they've given you a green piece of paper, or they're asking for your advice on a different matter and they're presenting to yourself. It doesn't matter. I don't see the money. I'm not a commercially driven person. As long as I've gone home and known that I've made a good intervention, whichever way it came into me, I came across it, I don't see that difference.
Okay.
Maybe it's naivety.
No, I don't think it's naivety at all. Now, Ash, of course, you have some very interesting views, I know, on how we can change the model. And obviously, with your RPS hat on, we couldn't possibly ask you to talk on contractual and money issues. But with your pharmacy owner's hat on, obviously you've got a very acute interest in this. So how can we change the model more to rewarding for outcomes? And let's not forget the self-care element of the question.
Let's go back to the question first, which was about actually the value that we get through self-care and through supplying OTC products. Actually, that's part of the continuum of care. And I absolutely believe we should not lose it, because it is part of the armoury that a pharmacist has, and hopefully as we strengthen that armoury, we can change and be able to deliver more. There's some interesting discussions you could have which get into using the OTC type market to manage long-term conditions by recategorising products, which I think are quite interesting and could be part of this type of discussion. But what you then have to do is recognise the fact that we are paid by the NHS. The vast majority of our income is from the NHS. And actually, one of the things we have a real issue, going back to, and I hate the term minor ailments, I prefer common ailments or pharmacy first, is that a large number of people, it's now 93 million appointments in GP practice, are for minor conditions, for conditions that could happily be treated by pharmacists using OTC products. Now, in those cases, we can sell them, but the reason they end up going to the GP is because they get them for free. So we have to recognise that. We have to recognise the way that people behave. So as a result, what you have to do is offer an NHS service as well, an extended service, which offers the opportunity for people to be able to go and get those products under the right circumstances in the same way as if they had gone to a GP. That is part of the continuum of care that you get. Now, alongside that, going to the outcome piece of this, what's really critical is that if we introduce those types of services, what we have to do is not necessarily pay, the product has to be paid for if it's supplied. However, the purpose behind the scheme should be about the service in terms of care that you have provided. So whether you've provided the appropriate advice, whether you've provided self-care in terms of going home and just looking after yourself, keep warm, drink plenty of fluids. There's nothing wrong with that type of advice. And I know the scheme we run locally, we're actually paid for those consultations, regardless of whether we make product supply or not. The problem with a large number of the schemes out there is that they are based on the principle that you have to make a product supply because they can't measure the outcome properly. From a commissioner's point of view, what they can measure is the output. And the output is, you gave something. It's an easy solution for a commissioner. It's much more difficult to do in other ways. But if we are going to truly make change, we have to be much more focused on that in delivering it that way. And actually, we have to recognise that pharmacy as a whole is still seen as a transactional service. We are not focused as well as we should be as caregivers. We don't operate in the way that we should. I'll use a story as well. If you turn around to the average person and say you have 6 minutes with a doctor or 6 minutes with a pharmacist, they'll be disappointed. Because it's too short with the doctor and it's too long with the pharmacist. Because they are seen in very different ways than what they are expected to do. And if we are to make this change, pharmacists absolutely have to be on the front counter. They shouldn't be in the dispensary. I try really hard in my pharmacies to get them to come out and actually not be in there. They do, they end up back in because of this control nature that pharmacists have and behaviour around risk and the General Pharmaceutical Council regulations and the consequences to them as professionals. But ultimately, if we can get them on the counter, they would do all of that continuum of care. So they would make the OTC supply where it's appropriate. They would provide the advice where it's appropriate. They would be able to support people to be able to get the best from any aspect of their care, whether it's from self-care, from long-term condition management, or acute. It doesn't matter. But that's where we have to get to, and that's why the pharmacist has to be in front of the counter. But the question itself is, it's a key part of what we do and what we offer.
And there are two requirements to enable that goal, that dream almost. One is access to the patient's record, because we can't do proper self-care without it. And two, something I read is opposed by some of the multiples, is patient registration. Register the patient in your pharmacy, have access to the healthcare, then boy, you can really provide a real health contribution.
Yeah, that's definitely an argument still to have. Anne, did you still have the mic there? Okay, all right, come back to you if you've got time. Wendy, is it?
Yeah. There's been a common theme today. Everybody who we would consider a leader in pharmacy has talked about being passionate about being on the counter and talking to their customers or patients, whatever we want to call them. Andrew also said that you need to recruit people who have the personality that you want them to display. So how do we recruit people into the profession who actively want to talk to customers and be on the counter, rather than people who are academic and have the ability to pass the exams?
So I think this is an answer, a question for you, Katy, having recently come out of the university system. Are we recruiting the right type of person at undergraduate level at the very beginning of the process?
I can't speak for all universities, but I can speak for my own, where current students, I was a member of the first cohort of Huddersfield, so we had nobody above us, so we were guinea pigs and we're quite unique in that. But we were lucky enough to, when we were recruiting the subsequent years, to actually be involved in that process. And if I went back to a lecturer and said, I can't count the amount of times somebody said, so why pharmacy? And they go, because I like chemistry and I like biology, so I like helping people, therefore I'll be a pharmacist. And I went, really? I hate chemistry. I'll do it because I have to. But I have that you can see it in people. But my argument would be, we are currently recruiting the right people, and we encourage them through university, and then we graduate, and then we lose them. Because it's it's the tipping point of the pre-reg tutor, and about how their opinions are instilled silently into those newly qualified and into those pre-regs. And it's disheartening for me as a newly qualified pharmacist, knowing my colleagues and being the president with 14,500 members. I know quite a few, can't name them all, but they come when I'll say, oh, how's it going? Oh, it's terrible. Why did I pick pharmacy? It's terrible. And it's because the higher generations of pharmacists have lost their way, and they don't have any motivation. But the newer, I can promise you, the newly qualifieds out there are there, but they lose their way. There's a gap in the middle. You've got the leaders, you've got the newly qualifieds, and you've got a generation in the middle that need a good talking to.
I think I know just the person to give them the talking to.
But I can tell you,
Sheila.
Some of the reason that generation in the middle is sitting there is, we hope lots of previous generations of pharmacists walked out to a guaranteed job. So you got really good A-levels, you went into a degree course which was far from easy, and at the end of it you were guaranteed a job. So employers really didn't have much choice. You have to have a pharmacist there, so you took what you could get. And so there are people who really were much happier being boffins and backroom people, or didn't really want to deal with customers. So more schools of pharmacy, against everyone's opinion, you churn out more pharmacists, you get more choice, and maybe you get different kinds of people going into pharmacy.
Actually, it's a real problem, isn't it? It would be professionally a disaster if we lose the enthusiasm and the commitment of these younger people coming through. So whose responsibility is it to kind of mentor young pharmacists going up to their 30s, and so we can capture or recapture what they've lost and keep them on track?
I think there's three...
Someone's got a mentor.
Oh, absolutely, and I think there is a key role that we can play in terms of how that can happen through the RPS or through the faculty. In fact, I happen to sit on an education board as well for South London, and I've just invested some of the resource I was given the opportunity to spend on behalf of them on community pharmacy, specifically on a programme of mentorship and leadership, which is designed to try and get us in a place where we start to get that back, that missing generation in a way. But one of the things I will say, and it is a lost, and you can describe it as a lost generation, you can describe it whatever way you want, but I don't think in some ways we're any different to the medical profession. That the medical profession, we're also taught historically in a very you will do. This is how you will treat patients. This is how they will behave. This is what you must do to them. And in a way, that became the way that the ethos that was created. And actually there's a realisation, and it's true across both professions, is that wasn't the way you treated people. And if you wanted them to make a difference, you had to have the right communication skills, you had to have the right knowledge, you had to care about them, rather than just be, I can tick a box and I can do something to you. And the newer recruits that are coming through, the graduates that are coming through, are much more capable of that. But what we haven't necessarily done is ensure that the pre-registration tutors that are supporting them as they come out have got that same enthusiasm and skill behind that. So if we can see through the mentorship program this requirement that that a pre-reg tutor has to have gone through and demonstrated they are committed to mentorship and leadership, and therefore have the skills to be able to help and support a graduate appropriately, they shouldn't be doing the pre-reg tutor bit. And I think one of the challenges for us professionally is to ask ourselves the question, the hard question, are we satisfied with the way that we currently do this postgraduate? And I don't think we do it well enough. I think that's a really difficult thing to say, because I think for the people that currently provide it, and wouldn't necessarily see that being the case. But if you get into a point where only half our pre-registrations are passing the exam, then we've got a real problem. Because actually, there's an issue about the quality that the quality of training they're getting. And as I say, the big piece of that gets knocked out is this ability to care. Actually, the other thing I'd say is that as a current contract, going back to the current contract, graduates come out, and I used to turn around and say, they come out, they're really enthusiastic, then I spend 2 years beating it out of them, because actually I want them to count bloody scripts and put tablet numbers, because that's what I get paid for. But that's part, and so the contract itself does not make that any easier. But actually, we need to take the enthusiasm of the new generation and use that to be the drive to create the change in the way that pharmacy provides healthcare.
That's some great answers. Great question there. Peter, then, before one more from the floor.
Very, very briefly, and far be it from me to disagree with Katy, because I'll get a jolly good talking to, and quite rightly so. But I have to say that one of the reasons you've invited me is because I'm a locum pharmacist. So my experience over the past few years, in answer to your question, is that I think there's still a considerable portion of pharmacy graduates whose scientific acumen exceeds their communication skills. Yeah. I really do. And there's also loads and loads of great graduates coming out who could talk the hind leg off a donkey, So there's a mix. And the responsibility for that mix at the moment has got to lie with the universities medicine changed its entrance criteria quite a long time ago to put less emphasis on high achievers and greater emphasis on people with communication skills. Perhaps pharmacists should look at that as well.
Very good. I think we've got time for one more question from the floor. Mr. Mason, mic down to the middle, please. What have you got for us, Jonathan?
All right. At the risk of throwing a hand grenade and really setting off quite a long debate.
We've got 5 minutes.
I've got 5 minutes. Okay. Well, I haven't got 5 minutes. You have 5 minutes. Keith Ridge recently made a comment about the number of pharmacies in England. He said some people, and I'm not saying who he was referring to, could be himself, say that there are 3,000 too many pharmacies in England. Is this a threat or an opportunity?
Who wants to take this one first? I'm very quiet.
I'll go. I think he's talking rubbish. Sorry, Keith, if you get something to hear about this. Actually, I think that's fine. To be honest, and Keith and I have had this conversation. But actually, he's right if you continue to do what we do today. If we continue to be transactional entirely, then actually the number of pharmacies probably is too great. We could probably deliver the model more effectively. In fact, if you read Roy Lilly, you'd have Amazon do the whole lot, actually. However, if we are to deliver the type of care that we're talking about here, and the need for us to do things very differently, then actually the number of pharmacists and the number of pharmacies probably isn't great enough. Because you then need to be able to provide more time, more opportunity for people to have that contact with the pharmacist. Now, that may be done through having more pharmacists within a single pharmacy, but have they got the space? I don't know. It could be by putting pharmacists in GP practices. I don't think that's a particularly great solution, personally. I think it's one of the tools you can do about supporting general practice, but I don't think it's the right model for care. But actually, at the end of the day, if you change that and you do get to a position where we're doing something different, we will need more, not less. Because we're already, going back to the comment you made, we're creaking now. Could you imagine the position we'd be in if we're suddenly having to provide 10-minute appointments to the people as well? We'd be back in the same position as general practice and saying, actually, no, I've only got 6, or I can only do 4. And it becoming shorter and shorter and tighter and tighter. Actually, you need to unpick that and start to see what is it we are going to do, and if you are doing the things that we talk about, which are supporting the dispensing process, because we mustn't lose that, that is a key part of the care pathway, you would need more.
I'll go to Sheila probably to close this, unfortunately. But Sheila?
We've got fewer pharmacies per head of population than almost any other country in Europe. And if you go to Belgium or France and stand on a street corner, you can see them, 4 or 5 surrounding you. There seems to be a kind of rough figure about how many outlets you need to sell medicines with professional help. And if we drop the number of pharmacies by as many as 3,000, we'd probably end up then with the growth of a model like the one in the Netherlands, where you have the druggists who don't supply prescriptions but sell virtually all over-the-counter medicines. So maybe saying that there's too many is a reflection of the fact that the cake is limited and the number of pharmacies has been going up and up, so that each individual pharmacist is getting very little money now. Obviously, if that number came down, then those pharmacies that survived would be much better off. But I think in terms of providing service to the public, you don't need 3,000 less. I can't imagine where you'd get the kind of number of outlets to sell medicines that you need.
And briefly then, Peter?
Gosh, Claire Dravada, who was the head of the General Practitioners College, she recently said that the sole contractor independent GP was an outmoded concept, and that they had to get closer together, work more collaboratively, and also work more collaboratively with their hospital doctor colleagues. So my take on this business of how many pharmacies should there be, it's not so much how many, it's what we do with them. And we need to align pharmacies or pharmacists much more closely with GPs. We need to have a collaborative sort of approach to healthcare on the high street between the pharmacy and the GP. I mean, how hypocritical of the man to suggest such a thing. I mean, they opened the door for the 24-hour, or 100-hour rather, pharmacies, and we see what an absolute nightmare that was. And so having lots more pharmacies in, they say, we may have too many.
Well, I think collaboration, good. Too many pharmacies, probably. I mean, I will say, just closing the session, that when we tweeted that comment, it was an inside government event, wasn't it? That, I think, was the most reaction that we've ever had to anything since we started on Twitter. It's clearly an incredibly emotive issue. And it's quite a complex issue too, and I think we've got a sense of that today. It's not as easy as saying there are too many pharmacies. Maybe the question is, what do we want our pharmacies to be doing in the future, and work from that basis. Well, I'm going to have to conclude it there. I'm really sorry, because that was an excellent session. It would be good to give it a little bit more time. But I'd like you to join me in thanking our panellists. They've been a great panel, have they not? Please show your appreciation.